Hi, this is Momortazabi, and I'm going to be um, going over our abstract looking at microsaccades as an oculomotor marker for concussion. Um, just a little bit of background on microsaccades. These are eye movements that are essentially small microfixations, and we sort of break down normal visual exploration into saccades and fixations, and think of fixation as periods of relative stability or when the eyes are fixed or fixated on an object. But the reality is the eyes are never still. So even when we're in gaze fixation, there are these what we refer to as fixational eye movements or microsaccades that are occurring, and these microsaccades are actually a normal part of visual function and a critical part of visual function because they're important in maintaining peripheral awareness and visual processing and visual integration. So, and when you fixate on an object, if you do that right now, you will find that you probably got about a 180-degree arc of peripheral vision if your vision's more or less normal. And if someone were to move their fingers in that 180-degree arc, you would be aware of it and you'd probably draw attention to it. And a big reason for that is these microsaccades are functioning properly and allowing you to really take in that peripheral vision and integrate it with your visual function. So here's an example of, on the graph, just looking at a microsaccade. These magnitudes generally are anywhere from 0.5 to 1.5 degrees. They're quick. They're actually very difficult to see grossly, and that's where we utilize oculomotor trackers and sophisticated tooling to measure them and follow them. But certainly if the microsaccade magnitude is high enough, and those of you that have treated a lot of concussions and seen some bad ones, particularly those that are significantly affecting the vestibulocular or the oculomotor domain, probably have seen some folks that they're trying to fixate for you, and looks like their eyes are bouncing around, and that certainly could be their microsaccade magnitude having become excessively high. But normal is generally between 0.5 to 1.5 degrees in magnitude, depending on the study you look at and what sort of laboratory settings they had. This is again on a graph, what you would see when those microsaccades are taking place during attempted gaze fixation. So the sort of the big question we're trying to aim to answer is can this be a important biomarker for concussion and prolonged symptoms and particularly visual subtypes. So, we know that microsaccades have been used in other neurologic diseases such as Parkinson's. They've also been used in situations of excessive fatigue or cognitive load. And we know in particular with concussions, we see folks that hit cognitive fatigue. And so the question is abnormal microsaccades potentially a player in that? And if so, then maybe it is an important biomarker for concussion, and also particularly those that develop cognitive fatigue or visual subtypes. So, it is ultimately a quick measurement. It's certainly non-invasive. It can be done with oculomotor trackers. It's, like I said, difficult to do without sophisticated tooling, however, in comparison to some of the other oculomotor movements like saccades and pursuits and near-point convergence that can be done clinically as well. And the results are relatively easily quantifiable. So what did we do? We had a healthy control data that we did baselines on 116 college athletes from Sterling College, and none of them had a history of concussion. If they did, we didn't use their baseline data, and we compared those to our concussion data over at the Spark Concussion Clinic in Tucson, Arizona. And these were 86 concussed patients, all of which who had oculomotor tracking tests done with microsaccades. All participants were age matched, so they were 18 to 23 years of age, both in the concussed group and the baseline group. And the equipment we used was, as I mentioned, an eye tracker, which is ultimately utilizes a Vive virtual reality headset and works at 250 hertz. And essentially, what these guys do is put on the VR goggles and are looking at a central white dot with a all black background, with their head stabilized in a steady position by the technicians. And they do a 20-second interval of this fixation exercise or test, and they do this 7 times. So it's a total of 140 seconds of fixational testing. And there's a total of 5 variables that are looked at with the fixational test, starting with the number of microsaccades, also known as the rate of microsaccades, and then the other big one is the size or the magnitude of the microsaccades. We also calculate the velocity of the microsaccades or the speed. As well as a visual area covered by the fixational movements. So that includes the total area of the fixational movements, and more specifically, we look at the vertical to horizontal ratio of the fixational movement. Microsaccades, normal physiologic microsaccades are more often in the horizontal plane. So we hypothesize that if we're seeing more in the vertical plane, that could be suggestive of some problems as well. And we used a log regression to do some of our basic stats for this pilot study, and this is what we saw. So there was a few variables of interest, but in particular, as you can see by the red box there, the microsaccade magnitude in the concussed group versus the baseline group was significantly different, with a p-value of less than 0.001. And the microsaccade rate was actually pretty close to being a significant p-value at 0.057, but certainly between rate and magnitude was the one that stood out for us. There does seem to be some level of maybe excessive rate as well, but magnitude was the key variable here in the concussed, where we saw greater magnitudes in the concussed population versus the baselines. And then another variable that was very important was looking at the vertical variance proportion, or in other words, the vertical component of the microsaccades, and those that had higher ratios of the vertical component, in particular, a 2-to-1 ratio vertical to horizontal or greater, we saw a significant p-value there, as you can see, 0.003 in the concussed versus the baseline group, of having not only as I mentioned previously, the excessive magnitude, but with this p-value in particular, the vertical component being more than the horizontal. So you can see here the area under the curve was 0.74, and we had a specificity of 0.85. So these fixational eye movements, particularly when you're looking at microsaccade magnitude, can really provide a highly specific marker for concussion. So here's the graph showing the blue, the non-concussed group, the orange overlapping was the concussed group. So you can see between 0.5 and 1.5 or so, you sort of have a mix of both. So certainly we had a good number of concussed patients where their oculomotor wasn't as affected. They didn't have as much microsaccades, or had very normal microsaccade magnitudes. But you can see that there's this heavy distribution in the tail with the concussed population. So there was a good number of them that had microsaccades that were greater than 1.5 to 2 degrees, which we just didn't see much of that in the baseline population. So basically, this sort of led to the threshold being right around 1.5 to 2 degrees on the microsaccade magnitude of about 75 to 80% for concussion or concussed in our data. Here's the plot graph, also more or less showing the same thing. You can see, in the normal range there, you've got a sort of, again, a mix of your baselines and the concussed that did not have as much oculomotor or microscopic change. But as you get outside of 1.5 degrees with the microscopic magnitude on the x-axis there, what you can see is you're starting to see majority of concussed patients there at about 70%. And then in particular, if you look at the y-axis where you're looking at the vertical to horizontal ratio there, so if you get that ratio greater than about 2, the threshold was 85%. Being concussed. And once you got above 3 for that ratio, they were all concussed in our data, as you can see. Again, pilot data didn't have the large numbers we'd like to have, but we're hoping to add to this as we move forward and have more to report. So what were the limitations? Well, fixational eye movements are only one part of the oculomotor metrics, and so we've done some research looking at a number of other ones, particularly near-point convergence over the last couple of years that we feel are also very important and in many ways maybe much more sensitive than microsaccades. But microsaccades may have something to offer in its specificity and also being specific more to those with visual subtype and cognitive fatigue, which could be important in targeting management. This was retrospective. We had a lack of control for the severity of the injury or the medical issue. We sort of basically, for the concussed group, essentially took all comers there. And the data was acquired, the baseline data and the concussed data were obviously acquired at different locations, and we had different personnel who were doing it, although they were all following the same protocols. So, what's the bottom line conclusion? Well, I think that the couple of lessons from this, the first one is that oculomotor, and we've seen this, over the last 5-10 years of research, that oculomotor and visual deficits are pretty critical to be looking at in concussed patients. They occur in the majority of concussed patients, 50 to 80% if you look at the literature. And in particular, you can break down the different types of oculomotor deficits. And abnormal fixational eye movements are one very specific, interesting oculomotor deficit that concussion patients have. And what we saw in our study is that larger magnitudes of these microsaccades, in particular greater than 1.5 degrees, was, and as you got into higher numbers of 2 degrees, definitely very specific for concussion and concussed populations at 70 to 80% at that point. And larger vertical components of motion, certainly a ratio of 2 to 1 or higher, was getting you into the 85% concussed. So again, specific markers there that can be very useful for potentially being not only markers for concussion, but again, like I said earlier, more importantly, because there's a lot of markers that can help us determine concussion, but this is one that can be a marker that can help guide the subtyping of concussion as visual subtype or a cognitive fatigue subtype or both. And that can really guide management with respect to return to learn, recommendations that you have, how much visual load can they handle, do they need vision therapy, do they maybe need prism orthoptics to help them with stabilizing their microscope, particularly if they've got a large vertical component, so on and so forth. So these are all areas that we're trying to look into further in studies. So, and that's where we have a lot of goals for future studies with this. But in particular, a couple of our goals are to refine our statistical model, have larger N, and also be able to look closer at some of the other non-fixational eye movements, like pursuits and convergence. And this is our references. And thank you for your time. And I wish you guys all the best. Be safe.